prospective multicenter study.
First of all, I would like to thank EuSEM's scientific committee for its kind invitation to be with all of you here, and of course to all the audience for your interest. I will only use about 7-8 minutes of the presentation in order to give more time for the questions. The study present has a beautiful name, you see, Thrombus. As you can see, it stands for Thrombosis Detection by Bedside Ultrasound. You can see it's a prospective, multicenter study, Diagnostic Concordance of emergency doctor-performed bedside ultrasound versus radiology, ECHO-Doppler, ultrasonography in the diagnosis of DVT of lower limbs. The study was fully conducted in Spain, and the leading hospital was Hospital Ramón in Cajal from Madrid. As you know better than me, DVT is an increasing major cause of mortality and morbidity, and there is a need for a quick, easy, inexpensive, convenient, and reliable diagnostic tools. Current available evidence suggests that emergency doctors can perform bedside ultrasound to diagnose or to rule out DVT in a quick, inexpensive, and accurate way in comparison with the gold standard studies by the radiology department. The main objective of Thrombus was to ascertain the diagnosis concordance of emergency doctor-performed ultrasound of the lower extremities with the specialist doctor-performed ultrasound in the diagnosis of DVT. Okay, you will be thinking that's not original. I have heard about this before, and maybe you are right, but not completely right, because Thrombus is not just one study more. We'll see why. Because important concerns have been raised about the interpretation of the available evidence comparing bedside ultrasound by emergency doctors and specialty doctors ultrasound. The current evidence say there are severe concerns about the small sample size of the studies, very different experience of the emergency doctors performing bedside ultrasound, or they are highly skilled. Of course, you cannot afford to have 5 doctors in your emergency department, or the lack of details involving patient enrollment. So at least we try to solve out all these problems. In this prospective multicenter study were eligible adult patients more older than 15 years old, with clinical suspicion of DVT, high or moderate risk of well scoring, or low risk with increased D-dimer levels. From September 2013 to September 2014, 320 patients were enrolled. 51 investigators, all were volunteer specialty registrar emergency doctors. So we are going to see now some of the differences from Thrombus in comparison with other studies. Our recruiters have not previously attended an ultrasonography course for DVT. They were novice sonographers, but they received an induction course, theoretical and practical, of basic ultrasound, 15 hours teaching, 2 days, with special attention to simplified compression technique, 4 hours only for this, in femoral and popliteal areas of the venous system of lower limbs. So, at least on a theoretical basis, our recruiters was an homogeneous sample. They were recruited from 7 hospitals throughout Spain, and each patient had the emergency ultrasound and the specialist doctor ultrasound, both in femoral and popliteal areas. The final result was considered non-concordant if one or both of the emergency doctor ultrasound did not match with the specialty doctor ultrasound. And we used that statistics method. Of 328 of ultrasound studies, 37 were not concordant between the emergency doctor and the specialty doctor ultrasound. But unfortunately, 2 of the emergency doctor ultrasound were incomplete. Therefore, our statistic told the concordance analysis could only be performed with 326 ultrasound studies with 35 discordant. In this table, we can see the mismatch of the emergency doctor and the ultrasound and the specialist doctor ultrasound. 22 given as normal by the emergency doctor were abnormal by the specialist doctor, false negative, and 13 given as abnormal by the emergency doctor were given as normal by the specialist doctor, false positive. So that makes the 35 discordant data. Our results were this. The percentage of agreement between the emergency doctor and the specialist doctor ultrasound was 89%. The Ctra index was 0.76, which means a substantial agreement. That's a statistical word. Well, these results were beautiful. These words are beautiful, but we try to go even further. We try to dissect these results of the mismatched emergency doctor and specialist doctor ultrasound. And notice actually very interesting facts. 56 of non-concordant results were in the first 2 performances of our recruiters, and 83 occurred in the first 5 performances. In this figure, we can see the total number of bedside ultrasound performed by each emergency doctor who made a mismatch related to the sequence number in which the discordant ultrasound was performed. We can observe that the lesser the number, the more frequent the discordance, or upside down, the more ultrasound performed, the less the discordances. In this table, we can see even more clear that most of the discordances of the mismatches were done in the 5 first performances. So the conclusions of Thrombus are: first, there is a substantial agreement between the emergency doctor performing ultrasound and the specialist doctor ultrasound in the diagnosis of DVT in routine clinical practice, even when the recruiters were novice ultrasonographers. Second, thorough examination of the Thrombus data suggests that it seems quite reasonable, if not mandatory, that emergency doctors performing ultrasound in the diagnosis of DVT should be shadowed by senior staff experienced in ultrasound, at least during their first 5 performances. And third, this will decrease the mismatch in relation to a specialist doctor ultrasound from 89 to 95%. We have no conflict of interest, and thank you very much indeed for your kind attention.
Any questions?
I missed the initial bit. But what are the kinds of DVTs that the emergency physicians fail to diagnose? Is there any particular grading or any kind of complexity?
I cannot understand properly what you mean with that.
Yes, label with the thrombus.
What kind of DVT presentations will be missed by the emergency physician compared to a specialist?
Well, the clinical, the patients should arrive with clinical suspicion. That could be because the family physician or general practitioner sent the patient with a query diagnosis of DVT, or just clinical suspicion by Wells score, education with a leg wider than the other, painful, anything that could that you could make a suspicion, the clinical suspicion of a DVT. That's in the Wells score.